So our session focused on the experience of what it was like to do this from the perspective of palliative care and the hospice communities. And the real focus of our session ended up being on how does a state, in this case California, but there was one other talk as well, how does a state actually, those providers engage with this as it becomes legal, and sort of how do you adapt to it? Personally, I learned a lot. I live in a state, Massachusetts, where I'm fully expecting this to become legal in 2020. And so therefore it was useful to be able to sort of see how people do it. And so here are my take-home points from all the talks that we had in our session. First of all, 3 basic underlying principles that were expressed. One was that requests for physician-assisted death must stimulate deep conversation and enhance quality end-of-life care. That seems to be the norm that does happen, and people seem to feel that it really has to be pushed to make happen more. The second is that context is all important. Politics are all local, and so similarly, ethnic variation is huge and must be accounted for and studied further. You can never separate from how this is done from what that local community looks like, and that's part of what's going on in all these examples. And then the third is that this issue is clearly complicated for physicians and other healthcare providers, and that moral distress is going to be out there, and that we have to acknowledge that, we have to manage it, we have to live with it and figure it out. We can't ignore it, even in states where legality has happened. Specifically then, several points about the practice and particularly how healthcare systems might actually adapt to this when it becomes legal, or if it does. So the first is that creating an institutional policy requires massive stakeholder engagement. Every single one of these places just reached out to as many people as they possibly could, focus groups and so forth, town meetings to make this happen. Second, patients must opt into these programs within health systems, and there was, I thought, universal sort of sense that they can't necessarily be offered it by providers. The third was that all the policies that people have been passing seek to enhance end-of-life care and to involve hospice, pulse, other related measures to make sure those things are all in place, either concomitant with PAD or perhaps separate from or preventive of. Next, that ideally systems provide for some level of patient navigation. It is difficult to make it through one of these any of these laws in any of these places, and particularly if you're operating in a health system, like a Stanford or UCSF or a Kaiser, patients need to have sort of a guide for how you make it through. Next, that secondary consultation is necessary in most of the laws, in all the laws actually, it's necessary at some level, and that the institutions need to figure out a way to offer that. And what we heard were a number of different possibilities: palliative care, ethics, psychiatry, one could imagine other mechanisms as well, but there needs to be a set way to be able to do this. Next, provisions must exist for conscientious objection, and that in every health system there are going to be people who want to have nothing to do with this, and that has to be allowed for and can't in any way affect anything else that they're doing. It also appears to be very helpful to have a list of willing prescribers. There was an interesting debate that began, I think actually it was Scott that brought up this question of whether it's better to have 1 or 2 go-to people or not. I think that's an unanswered question, and I think it's a really interesting one. In another issue, I almost hate to say it in this room, but with abortion, it's become this thing where there are abortion providers and sort of everybody else doesn't. There is good and there is bad in that. And I think we need to think about sort of how this plays out. We also need to think about why it's such an issue. And I think it has to do with stigmatization and so forth. And so that's one that feels sort of a little unpacked. Everyone involved must be educated on the law and best practices. If you're going to be involved with this and you need to know how to do it. I was at lunch and I was telling someone that I recently got approved to be able to certify patients in the state of Massachusetts to receive medical marijuana. And to do that, I had to take a 2.5-hour course in order to be able to do that. It should be at least the same one would expect with this. And finally, an interesting comment that came up in our session and came up in a number of other sessions as well was that presence at death by willing health professionals can provide great comfort to patients and family. And something just to think about is that I think a number of us have been at deaths in general. I mean, I've never been at the death of someone who was assisted. I've been at many other deaths. And I think we can often offer comfort in those settings. And it's clear that also exists here. And how can we try to make that happen?